Well, it's great to see everyone here today. For those of you whom I haven't met, I'm Lloyd Minor, Dean of the School of Medicine and Vice President for Medical Affairs of Stanford University. And I'm delighted to be here with you at this 7th annual Maternal Child Health Research Institute Symposium. And I want to begin by extending some very special thanks to Dr. Mary Leonard, Dr. Tony Oro, Mary Chen, and the entire MCHRI team for putting together this wonderful conference today. So the theme, of course, of today's conference is the application of AI in maternal and child health. And I guess maybe that's a part of a larger theme of the application of AI into all aspects of our life. And closely connected with that theme is the theme of how to rebuild and sustain trust in science. So how do we do science and communicate science in ways that engender and build trust? Two incredibly important topics given the world we live in today. I wanted to just say a few words, but mainly my role here is going to be to introduce our panelists who will each be giving a presentation and then to moderate a discussion that will very much involve all of you in asking your questions. So I want to talk a little bit about what we've been doing in the School of Medicine and Stanford Medicine and Stanford University in the application of AI, all the way from how we educate the next generation of physicians and biomedical scientists to the way in which we empower discovery-based research, enable translational research to take fundamental discoveries more rapidly to the benefit of patients, redesign clinical trials in ways that are more efficient, as well as in ways that get to definitive solutions and answers in a faster way. And of course, how do we modernize and bring up to the digital age our healthcare delivery system? Recognizing all these opportunities and also the fact that we are a part of Stanford University, which has a very long and storied history in artificial intelligence. Indeed, the very origins of the field began here at Stanford, and we benefit from having an exceptional engineering school, computer science department, statistics department, as well as our own initiatives within the School of Medicine related to AI and data science. Recognizing all of these resources, in the summer of 2023, Dr. Fei-Fei Li, professor of computer science here and the artificial intelligence expert who's been dubbed by the popular press as the godmother of AI, we put together an initiative that we call Raise Health, Responsible AI for Safe and Equitable Health. Now, Raise Health is not an institute. It's actually a collaboration between Stanford Medicine and the Human-Centered AI Institute of Stanford University. But hopefully what Raise Health will be and is being is a convener of thought leaders both within the university and externally, and through that convening power, becoming a repository of information about the responsible implementation of AI throughout the biomedical and healthcare delivery landscape, and also convening people to consider the ethical uses of AI and to support work that helps to define and then implement the ethical and responsible uses of artificial intelligence. And that latter topic of ethical and responsible usage of artificial intelligence is not a trivial topic. For those of you who are at Stanford, you know that we, Stanford Medicine, implemented a secure GPT system, which anyone in the Stanford ecosystem has access to. The way that system works is we in-licensed GPT 4.0 so that we have the large language model working on our systems. The advantage is that any query you type into that system, the secure GPT system, stays within our ecosystem. Now, why is that important? It doesn't go outside of our ecosystem. Why is that important? Well, in this world of generative AI, you could type a very innocent query regarding a patient without any PHI in the query, and yet just from the way you phrased the query, from the information you gave it, which might not have anything that the government would consider to be PHI, just from that information, it could conceivably lead to the identification of a person. Consider this example. Say you're seeing a 30-year-old patient with SLE who recently traveled to South Africa, who returned a few days ago, who's having high fevers and has an infiltrate on the chest X-ray. Well, if that person had a social media account where they had talked about their recent trip to South Africa, and if they were also a member of social media groups for patients with SLE, and given that if the data was allowed outside of our system, the location of the query would be known, all of a sudden you see how these things could be pieced together, right? So we're having to think about protecting privacy in new and very important ways. And we're also, of course, aware of the ways in which bias comes into AI. And indeed, the saying is so true that AI is no better than the data on which it's trained. And in the last session, you heard from Kurt Langlotz and others about how there's been a dearth of pediatric data used in training algorithms and AI models that are used today. And clearly, we at Stanford and the MCHRI can and should play a role in changing that. But the identification of sources of bias in the application of AI and the remedying of those sources of bias is a major goal, not only of Raise Health, but what we do in our ecosystem. So we have faculty working in our Department of Emergency Medicine, for example, that are looking at algorithms used to screen or to identify the probability that a person presenting to the emergency department with a complaint of chest pain, the probability that that may be a coronary event. And what was discovered in studying those algorithms and looking at what those algorithms were telling physicians relative to what we were finding in our patients, it was discovered that because the algorithms were trained with data that wasn't demographically representative, that the algorithms were not guiding physicians in a responsible way in patients who weren't represented in the training data. And so what have we done? First of all, identify those sources of bias and then get data into the training of the algorithms that's more broadly demographically representative of the US population and of the people we see in our emergency department. These are the types of things that we hope we can stimulate an interest in through Raise Health and through some seed grant programs, look at stimulating some early stage research, particularly on the ethics and the ethical implications of AI in healthcare delivery. I think those of us who've had an opportunity, probably everyone here has had an opportunity to use large language models in some way. The last session, that the Google Notebook LLM large language model, I think was mentioned, but where you can take a PDF of any paper you want, feed it into the large language model and get back a slide presentation, a synopsis, even a podcast involving two artificially generated speakers talking about the article. So you can read it, you can learn about an article on your way to work by listening to a podcast in the background. You know, the way we obtain knowledge, the way we generate knowledge is being radically changed as a result of large language models, and we're still at such an early stage. It was, you know, it was less than 2 years ago that the first primitive large language models came onto the scene. So a lot for us to think about, a lot for us to do. I'm going to now introduce our panelists, and they'll come up and give presentations, and then we'll all convene here to respond to your questions. We have the privilege of hearing from three very distinguished experts on this morning's discussion and panel. First, from Dr. Christopher Longhurst. Many of us remember Chris when he was here on our faculty in pediatrics and also at our pediatrics hospital. But Chris is now the System Chief Medical School Officer and Chief Digital Officer at UC San Diego Health. And then we'll hear from Professor Michelle Mello, who's a professor in the School of Medicine and the Law School, and who's one of the country's leading experts on the application of the ethical application and the legal applications of technology in health and healthcare. And then from Dr. Kristen Beam, who's a neonatologist at Beth Israel Deaconess Hospital System and Boston Children's Health, in Boston. So let me first turn to Chris, and we're looking forward to your remarks, Chris. Thank you.
Well, it's a real pleasure to be back here, and I want to thank Dr. Miner for the introduction. I want to thank Dr. Leonard for the invitation, and it's just terrific to see everybody and wander around the farm again. So as we get these slides up, I'm going to warn you, I'm planning to speak fast because we had such an engaging conversation at dinner last night. I wanted to hit on a bunch of things today, and so I just couldn't slim the slide deck down. First of all, no conflicts, always looking for them though, so please contact me afterwards. Secondly, we're here on the 25-year anniversary of the release of the Institute of Medicine report. That report, To Err as Humans, suggested 50 to 100,000 Americans die on an annual basis from harm that comes from our medical system. In fact, it was that report which incentivized and motivated the Lucille Packard Children's Hospital Board of Directors to invest in a computerized physician order entry system to help reduce the risk of medication safety and medication harm. And the follow-up report that came out in 2001 when I was an intern occurred while I was writing orders like this. So some of you recognize a neonatologist there, Dr. Palma. Dr. Alan Schroeder hasn't changed much, so good on Alan. But these were the kind of orders that we used to write when I was a resident here. I think Dr. Stevenson, Dr. Chamberlain, and others remember these orders. This actually came from the Hall of Shame that Bob Poole and Fred Nishioka would actually share with the interns every summer. It was the kind of orders you didn't want to write as an intern. So what's wrong with this paper order? Anybody? Dr. Langlotz? So there's a morphine abbreviation there, and the decimal point didn't go through the triplicate, and that baby ended up getting a 10-fold overdose of morphine, needed to be re-intubated. Okay, so those were the kind of medication errors we were hoping to reduce. Did we? Maybe a little bit. In fact, at a national level, a lot of that original research that led to the IOM report was published by Dr. David Bates at Boston and colleagues. And just recently, he published a follow-up article looking at all the discharges from Boston area hospitals. Now, Boston thinks they have good hospitals, right? 1 in 4 patients discharged from Boston Hospital had experienced an adverse event, and at least half of those were preventable. And in fact, many experts in patient safety say we've made little progress over 2 decades. Possibly some improvements in healthcare-associated infections, but overall, really insignificant progress. But what about children's hospitals? They're different, right? We've really doubled down in children's hospitals. We've got SBS, Solutions for Patient Safety. We've got collaboratives that have been working on this. Well, Dr. Paul Sherrick, who was a quality leader here for many years and one of my mentors, has been doing a lot of research in this area, and Paul's gone on the record at the Children's Hospital Association as saying that there is no clear evidence that adverse events causing harm have decreased in children's hospital over time. So we've got problems, and what I really want to talk about today is solutions that are AI-enabled, that are implementation science, right? And so I got together with Dr. David Klassen, who's one of the experts in patient safety, and is worried that over the course of the last 2 decades of his career, despite all the resources we've invested, we really haven't seen much improvement. And with Dr. Klassen, we looked at the literature on areas where AI and machine learning have been shown to help. In fact, we published this in January 23, which occurred, of course, was just a few months after the release of GPT. So none of this even includes large language model enabled work. But there's clear evidence around things like chest x-rays. Dr. Langlotz talked about isolated lung nodules, and I'll give you one example at UCSD, where the pandemic started about 6 weeks earlier than the White House had declared it. Because at Miramar Air Force Base, where, of course, Top Gun was filmed, we were the site of expatriates being evacuated from Wuhan, and we hospitalized one of the first 3 COVID-positive patients in the United States. And because of that, we launched all of our processes and command center back in early February. And as a result, Dr. Albert Schau, who is one of our radiologists and had developed a machine learning algorithm to identify COVID pneumonia, came to me and said, can we put this in production? It was actually peer-reviewed at that point, not yet published. And so we had no other priorities. We sat down in a conference room on March 13th, a Friday, when the White House declared the pandemic, and 2 weeks later we went live. I walked through the emergency department on Monday, April 1st, and I remember asking an ED attending, hey, have you seen the colors on the x-rays? Has it made a difference? And she said, actually, we just saw a patient yesterday, and the patient was brought in for concern about worsening heart failure. We got a chest x-ray to look at the heart, even though there were no respiratory symptoms. But there was color on the film. The radiologist didn't mention anything. But because of the color, we got one of the 6 COVID tests that were allowed per day. I said, well, what did it show? She says, well, that was this weekend. It takes 48 hours. I said, well, can we look it up? So we sat there together, looked it up, and sure enough, that patient was positive. And you can imagine I followed that patient very closely. It was one of the first community-acquired COVID cases in San Diego. And we proactively hospitalized that patient when she did develop respiratory symptoms. And she ended up not needing critical care and was able to go home healthy. And to me, that was a really great example of AI helping us make a diagnosis earlier than we would have otherwise. But it was also anecdata. And I learned here at Stanford, we need to be rigorous in our outcomes-based approach, right? So we studied it. Over the course of the summer of 2020, we asked every single physician who cared for a patient who got a chest x-ray, did it make a difference? And we partnered with our radiology team and our emergency medicine team, and we found that not only was this easy to use, but in 1 in 5 cases, it actually changed the clinical decision. So it had a significant impact, right? Now, there were 2 lessons learned from this study, though. The first was that there was an extinguishing effect. It wasn't statistically significant, but by the end of the summer, it was actually much less useful. Why? Because everybody who was walking in the ED was getting a test, right? It was ubiquitous, and that's what it was helping you do. And so by the end of the year, we turned off this decision support, which really illustrates the importance of ongoing monitoring, right? But the second thing was when my Google Scholar alert triggered one of the citations of this paper, and I read this article with great interest. It was a review article published just last year about all the AI articles published during the pandemic. And it turns out there were over 9,000 just in 2020 and 2021. And of those 9,000 articles, only 4 had clinical outcomes associated with them. 2 of them were international and 2 of them for the US. So you imagine I was paging through there, curious. How surprised I was that one of those 2 was the article I just showed you. Now, this is not God's gift to outcome articles. It was a survey-based research article, right? But it shows a real problem, and I challenge this audience to think about this as Dr. Miner was saying. How are we going to use these algorithms to actually drive differences that are meaningful to our patients and the families that we serve, right? So this is another review article in Critical Care, which shows that over the last decade, the paucity of outcomes evaluations, everybody publishes about their article, about their algorithm, but it's about their predictive value. And I'm sorry, I don't care about your predictive value. I don't. In fact, we've got history around just this kind of thing. In the early 2000s, editors of journals got together and said, we're no longer publishing these small GWAS studies because we're finding spurious associations and they're not biologically plausible, right? And then later, they did the same thing with microarray data. And I think it's time for the editors of journals to get together and say, we shouldn't be publishing algorithm validation anymore, because what we need to be doing is looking at meaningful outcomes. In fact, I'm going to share a story about how predictive values of algorithms don't translate to algorithms. And this is another area that we identified real opportunity, and I think this is important in pediatrics and particularly in neonatal medicine, which is sepsis prediction. So I don't have to tell this audience that sepsis is important. 1.7 million adults develop sepsis. 18 children die every day of septic shock. And in San Diego, I helped to recruit Dr. Shamim Namadi from MCHRI. And Shamim had been doing AI sepsis research for 6 years at MCHRI when he came. And I asked him when he interviewed, why are you interested in coming to San Diego? He says, Chris, I've been working with the VA, I've been working with MCHRI. I haven't been able to implement anything I've done. And I said, well, Shamim, if you come here, I guarantee you will, because we're not doing well in sepsis. We have a lot of opportunity to improve our outcomes. And so I paired him up with the chair of our sepsis committee, Dr. Gabe Wardy. I said, you two need to be best buddies, because we need to do the iterative improvements, the sepsis bundle compliance, the process improvement. But we also need to find a transformative way to improve our outcomes, right? So the first thing they did is they started putting a bespoke algorithm in, and they wanted to gain the trust of clinicians. And so they actually taught their algorithm something that hadn't been done before, which was how to say, I don't know, In the case of low confidence, our algorithm doesn't make a low confidence prediction. It actually says, I don't know. Because what generates trust more than being transparent about when you don't know, just like a clinician you hope would, right? So about 6 months after Shamim landed, I said, Shamim, tech team tells me we're getting all the pipes set up. How's it going from your perspective? He says, Chris, I go to the hospital sepsis committee every 2 weeks. I said, great. He says, I've learned more in the last 6 months than I had the previous 6 years. I said, what do you mean? He says, Chris, I got this great algorithm, but that's not the key. He says, now I understand. It's really hard if we're alerting the bedside nurse, but the nurse doesn't have the scope of practice to order the missing labs. And if we're alerting the clinician, but the physician isn't in the chart. So we need to figure out how to asynchronously do it. And turns out clinicians don't respond to alerts, and so we're looking for something more highly reliable, like our code team. Because it turns out our code team as a mid-level provider has a scope of practice to order labs, and we create a policy to do that, and redesign some workflows. And then Shamim said to me, the other problem is that my algorithm is optimized for about 4 to 6 hours prior to the diagnosis of sepsis, but we're starting to see the clinicians already have a suspicion at that point. In fact, it may be that my algorithm is inadvertently using data that encodes clinician suspicion of sepsis, like ordering lactate values. And so we optimize the algorithm to fire 10 to 12 hours in advance. And guess what? We lost predictive value, right? It doesn't work as well. But when it is accurate, it makes much more difference. In fact, you can imagine how thrilled the team was in January to publish this work in Nature, showing that the implementation of this algorithm over a 2-year period was associated with an almost 20% decrease in mortality from sepsis in our emergency departments. This translates about 50 lives saved at UC San Diego Health on an annual basis. Because of the process change, Dr. Pagler talked about people, process, and technology, and this was a great example, right? I also want to talk about something else that Dr. Pagler brought up, which is really important, which is bias in these algorithms. And Dr. Miner talked about the RAISE program, which is really laudable. It is true that all algorithms are going to have some bias in them, right? Because all of our data has some bias. And just like our implicit bias training, we need to be aware of it in order to acknowledge and mitigate that bias, right? So we worked hard on this implementation to understand our health disparity data. At the time, we had 2 emergency departments, now we have 3. And across those 2 emergency departments, we see a different population of patient with sepsis. In La Jolla, we tend to see our patients with cancer, right? They account for the bulk of our septic patients. It turns out our emergency medicine faculty are pretty good at early identification of sepsis in cancer patients. In fact, the implementation of this algorithm was associated with a 12 to 14% decrease in mortality in that population. But in Hillcrest, where we serve a very different population, our immunocompromised patients tend to be younger. They're more likely to be immunocompromised for other reasons, such as HIV. And we weren't doing as well in that population. In fact, the implementation of our AI algorithm resulted in a 24% decrease in mortality in that population. And so this is an example of how we used AI to address health disparities and close gaps in health equity, right? And it's not because the algorithm didn't have bias. It did have bias. It's because we addressed that bias in a meaningful way to drive the outcomes that we wanted. In fact, when this paper was published, the editor of the journal, Dr. Joe Kvetter, wrote this editorial I really appreciated called Integrating AI into Healthcare Systems More Than Just the Algorithm. It's a great editorial, and it dives into a bunch of things that they've identified as best practices beyond the algorithms themselves. But again, he advocates that the researchers, journals, and funding agencies alike need to shift the focus from measuring just algorithm performance to meaningful outcomes. And I think that's where Stanford really has an opportunity to lead. At UC San Diego, I founded the Center for Health Innovation about 4 years ago, and our mission is innovation at scale with impact. We started doing a bunch of remote patient monitoring, about 5,000 of our patients, and layering AI algorithms on top of that. And because of some of the early work, very grateful to receive a generous gift from Erwin and Joan Jacobs. And the Jacobs gift has allowed us to really accelerate and scale this with resources that are not dependent on the hospital margin. And so I want to share a little bit about what this has enabled from an AI governance standpoint, just to wrap up. So 5 years ago when Shamim arrived, I founded our governance committee. Like Dr. Miner described, we want to do this in an ethical, safe, respectful, and trustworthy manner. And the principles there, they're motherhood and apple pie, right? It's hard to argue with what's there. But applying those principles actually is where the rubber hits the road. And I'm going to share a story with you I shared at the White House when I was on a task force last fall that resulted in this executive branch announcement in December. And you'll see in there, not only was UC San Diego a signatory, but it encompasses some of what I'm about to talk about. So the story here starts November 22, when those large language models were released. And Dr. John Ayers called me up and he said, Chris, you played with GPT? I said, of course, it's kind of blowing my mind. He says, well, I'm feeding it patient questions and the results are kind of blowing my mind. I said, really? He emailed over a few. And sure enough, it did a really good job to responding to Reddit questions. And I said, well, this is probably worth looking into a little bit more. He sent me a spreadsheet with 200 questions and blinded responses, either doctors or chatbot. Now, while I was putatively anonymized, it wasn't hard to figure out which was which, because the doctor responses were typically 4 sentences, and the chatbot responses were like 4 paragraphs, right? So the clickbait headlines that came out of this paper when it was published in April were that the chatbot was higher quality and more empathetic than the doctors. But that wasn't my takeaway. My takeaway was it was about time, right? In a short period of time, the chatbot could construct what appeared to be a high-quality, empathetic response. But you give my doctors 10 or 15 minutes per question, trust me, they'll beat them every time, right? And so that gave me an idea. I called up the CEO of Epic and I said, I think I got an idea here. And they said, perfect, we're working with Microsoft to integrate GPT. And as a result, Stanford Adult and UC San Diego were the 2 pilot sites for this GPT integrated in-basket response. And we sat down with our governance committee before we went live. And the first thing we did is we said, well, one of our principles is accountability. And so we're going to make sure there's a human in the loop. There's no button that says just send now. There's a button that says start blank reply or edit the draft reply, right? And that's how we keep a human in the loop. And that's how we applied that principle. But we also have a principle around transparency. And a lot of times you think about that in AI as transparency of the data set that generated that algorithm. But in this case, one of our actually patient and family representatives on our AI governance asked an interesting question. She said, well, should we be transparent with our patients about the use of AI? And our doctor said, yeah, we use dot phrases today, and we don't have like an addendum that says dot normal labs was used to reply, right? But the patient and the bioethicist said, AI is different, scary. Patients don't know what it means. And so we ultimately made a decision to put an addendum. Anytime a doctor actually used the start with draft button, we paste an addendum saying part of this message was generated automatically, reviewed, and edited by. Now, I will say Stanford Adult took a different approach. I know Stanford Children's is considering this addendum-based approach, but it got a lot of attention as recently as 2 weeks ago in the New York Times when Teddy Rosenboth wrote this article, and both of our institutions were quoted about sort of the different approaches. And you can see, one of the subtitles there was, many have no clue the replies are software generated. It was really focused on this issue of transparency, and I think that's something that is going to deserve a lot more attention. In fact, it's got the attention of one of our Assembly members, and Assembly Bill 1030 was signed into a law a few weeks ago by the governor, which actually requires disclosure to patients when AI is used in communication with patients. So what else? Well, again, we've got to rigorously evaluate these outcomes, and so we did. In fact, we randomized and we partnered with Stanford Adult on this. In fact, you can see Dr. Topher Sharp from the Adult Hospital as a co-author on our paper. Ming-Tai Seal, our lead author, was co-author on the Stanford paper that came out at the same time. And it was interesting. We took a different approach. Stanford did a case control. We did the randomization. And in our study, we found it did not save time. It did generate responses that were 2 to 3 times longer. We also found it reduced cognitive burden and reminded our clinicians to be empathetic. The Stanford case control study actually found a measured decrease in burnout, right? And so that's fundamentally, I think, one of the lessons learned so far. The messages are longer. They're not taking more time, but they're not saving time either. But I think another really important point is that we randomize this as a QI study. And in fact, this was supported in our Journey to Learning Health System by the fact that we have a committee that actively looks and can affirmatively stamp quality projects with an IRB excusal. We wrote about this project, which now has over 400 active quality management cases that our trainees can use and partner with faculty on. And I think this is really important in this journey to a highly reliable learning health system. So I'm going to wrap up just by saying, I wrote this a decade ago with Dr. Bennett and Dr. Butte and some others about the opportunity to transform neonatal and pediatric care with translational bioinformatics. One of our next speakers, Dr. Beam, was a co-author on this one about transforming neonatal care with artificial intelligence. I look forward to hearing more about Dr. Beam's work with Neomind AI. And I think there's just tremendous opportunities for us all to collaborate to focus on clinical effectiveness, to focus on the outcomes that matter to the patients and the families that we serve. So again, thank you very much for the invitation to be here, Dr. Leonard and Dr. Miner. Really appreciate it. Looking forward to the conversation.
Thank you, Chris. Thank you. And next, we have the privilege and pleasure of hearing from Professor Michelle Mello. Michelle is a professor in the Stanford Law School and also in the Department of Health Policy of the School of Medicine.
Thank you. Thank you so much, Dr. Miner, and thank you for the invitation to be here. It's always nice when a lawyer gets invited to one of your parties. And I promise to deliver some legal advice that is worth every penny of what you're paying for it. I know that the theme of today's symposium is about cultivating and maintaining trust. And so while there are a lot of things I could discuss in the realm of the law and AI, I want to focus on three pretty disparate topics that I think all are united by their potential impacts on trust. Before I begin, a few disclosures. I do have some relationships with AI-adjacent companies. So I want to talk about three things. The first are some new rules around sharing patient data that implicates reproductive privacy. The second are new rules around algorithmic discrimination. And finally, I want to talk about recent court rulings that have to do with our ability to regulate physicians who spread misinformation about vaccination, COVID, and other topics. So being a lawyer, let me start with some cases here. Let's take this case first to talk about reproductive health care privacy. So this case concerns clinical care for abortion. It could just as easily involve research data that have been collected on a patient's history of abortion care in a state where abortion is no longer lawful. And it has been suggested that the same sorts of issues now may or may soon apply to gender-affirming care in states that have taken steps to restrict that. So it's highly salient to the care of women and children. There's been a great deal of confusion about the role of our primary federal health information privacy law, HIPAA, in regulating disclosures of this kind. The truth is that historically, HIPAA has permitted, but has not required, disclosure of this kind of information in response to a law enforcement request. To have a law enforcement request, you have to have a warrant or a subpoena. A subpoena is not that hard to get if you have reasonable cause to believe that somebody may have committed an unlawful act. And so historically, while hospitals haven't been allowed to spontaneously report to their attorney general that somebody has engaged in illegal behavior, they have been at liberty to provide that information, and many have done so. There are countless cases in which patients have been criminally prosecuted for unlawful behavior using their own medical record data, for example, on drug use during pregnancy. So it's been a real issue, and Congress has taken an interest in this, of course, since the Dobbs versus Jackson decision restricting abortion care. We do now have a new rule issued just a couple of months ago that clarifies and strengthens protections for these data. So I want to provide some broad contours of that. The Affordable Care Act and HIPAA are both relevant in this space. HIPAA provides that according to this final rule, that a hospital now cannot disclose this kind of reproductive health data in response to a law enforcement demand if they believe it to be in connection with an action to prosecute or hold that person civilly liable just for the act of getting the care. This has some substantial restrictions. It doesn't apply if the care that the patient received was not lawful under the situation where they got it. So if you're providing that care in a state where it wasn't legal for that patient, or in a state where it's legal but not for this patient for whatever reason, this doesn't protect the information. It doesn't apply if the law enforcement demand is in connection with some different investigation like sex trafficking or drug use. But, and it doesn't apply in any action that relates to professional malpractice. So if a physician is being accused of professional misconduct, unprofessional conduct, or medical negligence, it's still possible to get at this information. But it does strengthen and now flip us from a regime that was permissive of this to one that is prohibitive of this. Now, Republican state attorneys general worked very hard to prevent this proposed rule from becoming final. They didn't succeed, but they didn't give up. And so as recently as last month, there were noises from the Texas Attorney General about trying to unravel this through litigation. That litigation has now been filed against the Biden administration. The allegation is that it interferes with the right of states like Texas to enforce their own reproductive health care laws. Unfortunately, they have chosen to file it in Texas. We have a lot of judges in Texas that are very sympathetic, both to abortion restrictions and to the idea that federal health agencies have been overstepping their authority in various ways. And so this is now pending before a district court judge. It will go to the Fifth Circuit, which is extremely friendly to those kinds of arguments. And we'll have to see what happens. The good news is for providers in California, we have our own state laws that are quite powerful shields from this kind of disclosure. These laws were passed after the Dobbs decision very quickly by the state legislature. And essentially, they're quite clear about prohibiting healthcare facilities and other corporations in California from releasing this kind of sensitive patient information about reproductive care. Interestingly, one of these things actually applies to health plans. So a patient like Sophie, who's worried that the billing of her abortion care will alert people in her home state who might then disclose it, or her parents who might take adverse action against her, can now file a written request with the health insurer not to release that information to anybody but her. But her providers would need to advise her to do so, and do so in a timely way, and hold billing until that request gets approved. But there are at least shields here in California that would be helpful in a situation like this, and that I believe also could be invoked in the context of a law enforcement request for research data. So let me move on now and talk about the second sort of new development on the legal regulatory front, and that is a rule issued earlier this year relating to algorithmic discrimination. The Affordable Care Act has long had a section in it that prohibits this kind of discrimination, but the new rule sort of raises questions about how it applies to AI. This case, I think, illustrates some of the questions that might come up. So what does the ACA have to say about this? As you probably know, if you take federal health program dollars, you are subject to the ACA's prohibition on discrimination on the basis of these several protected characteristics. And it has been thought for a while that this applies to clinical decision support tools. It's been a little unclear. It's no longer unclear. The Federal Office of Civil Rights has now clarified that indeed it does apply, and that includes AI-driven clinical decision support tools, but is not limited to those tools. So if you have existing like predictive risk scores that are more old school or rule-based, it's going to apply to those too. This new rule does two things. One, it requires hospitals, clinics, and other regulated entities to take reasonable steps, make reasonable efforts to ascertain which of their CDS tools use protected characteristics as inputs. And second, for those that do, it requires them to make reasonable efforts to mitigate the risk of discrimination. So what does this mean? I have gotten a lot of sort of downloads from individual physicians who are worried about this law. And I think the perception is that it very much targets frontline physicians who are using AI tools, often with no idea what goes into them or how it drives outputs. So let me offer a few points of reassurance. One is that, contrary, I think, to their perceptions, this does not prohibit the use of those protected characteristics in CDS tools. In fact, if you read the very lengthy final rule, there are examples of using age and other protected characteristics as acceptable uses of these protected characteristics. But you have to be able to demonstrate that the use of these inputs comports with best practice or is otherwise clinically indicated. What does that mean? It's not entirely clear, but there's some leeway for professional discretion and judgment here as long as it's given some thought. But this is problematic because many times the people who are developing these tools are not clinicians. Oftentimes the inputs are determined, they're sort of reverse engineered, not from judgment about what should drive outcomes, but from what the data tell us about what does drive outcomes. And for those kind of tools, there's potential liability here. The second point of reassurance I want to offer is that physicians are not the target. Physicians are regulated entities. If you process Medicare or Medicaid claims, you're a regulated entity. But the primary target for OCR has always been hospitals and physician practices. So physician users, especially since they're not responsible for implementing or reviewing these tools, are unlikely to be kind of on the pointy end of the stick. And the third point of reassurance is that if you are on the pointy end of the stick, even though in theory you can be fined or terminated from Medicare and Medicaid, in reality that never really happens. Nobody wants that. That's a horrible outcome. So in practice what happens is a corrective action plan, which is a pain in the butt, but not kind of the nuclear option that a lot of people have in mind. I am, though, a little bit concerned about the implications of this new rule. One reason, as I've alluded to already, is it can be quite hard to ascertain what is going into these models, particularly if you didn't develop them, and the extent to which they're driving outcomes. Developers are not always super forthcoming about that, in my experience. And the second is that OCR seems to think that one can obtain information about bias and use of protected characteristics from the developer and check your list off as completed. In fact, if you read the fine print of the rule, the government estimates that the annual cost of complying with this rule, that is to say, identifying all of the clinical decision support tools in use here at Stanford Healthcare and determining whether any of them provide a risk of discrimination, the annual time estimate for that is 1 hour in the first year, 30 minutes thereafter. So about as long as it takes me to get a sandwich at Tresidder Union is the estimated amount of time. That, again, assumes that we're just getting information that's already out there, and critically assumes that we're not doing any site-specific assessments of bias, because anybody who does that knows that we're talking about more than a half an hour. So unclear kind of how they will go about enforcing this rule, but they don't seem to have a good understanding of what this actually can involve. And then a third issue that I worry about is sort of like what is discrimination? So a lot of this is in the details. Title VI, which is kind of the underlying statute here, protects against both the kind of discrimination you're thinking about and reverse discrimination, which means discrimination against white patients or people without disabilities. And what this raises for me is the possibility that we can't make a judgment about whether a tool discriminates or not without knowing what the indicated policy or clinical action is that people are going to take in response to that tool. So to go back to the no-show tool, suppose we do identify that black patients are much more likely to miss their clinic appointments than white patients. Is that going to be used to provide additional outreach or transportation services to those families to get them to their appointments? Or is it going to be used to double book those appointments so the clinic doesn't lose money? Depending on how that goes, that may have a big impact on how the Office of Civil Rights sees that action. That actually both of those might be discriminatory, particularly if a white patient can now come in and say, okay, you're getting all these additional services to black families. I could use transportation too. I've been denied it based on my race. But as a practical matter, the government is likely to be more interested in enforcing this if it's operating to the detriment of vulnerable patients. So I think this is going to pose some real challenges for hospitals. Let me wrap up on this, again, on a sort of different aspect of the theme of trust with another topic I've been thinking a great deal about since COVID, and that is what we do about the problem of medical misinformation. I think you're going to have some more sessions on this later today. So let me give you this case. Unfortunately, this problem was all too common during the pandemic, and medical boards were really under a great deal of pressure to go after physicians like Dr. Kennedy for unprofessional conduct for this kind of advice. Here in California, we took a very unusual and short-lived step to try to prevent them from doing so. So I thought I might comment just briefly on this failed policy experiment. The legislature passed a statute that defined unprofessional conduct in these terms. The medical board had extant authority to go after people for unprofessional conduct, of course, but it was not clear whether this would constitute it. Now it was, and it sort of reinforced their authority to go after people for this. Not surprisingly, this law was pretty quickly challenged, even though it had been narrowed from its original version, which applied to all kinds of things that physicians might say on social media or in public statements, to just patient communications, providing treatment or advice in a medical relationship. Physicians who got investigated challenged this law, and they succeeded in getting a preliminary injunction in a trial court that stopped implementation of the law. And the legislature, in a pretty unusual move, actually took the step of repealing the law pretty quickly. So this law is off the books, which leaves us kind of just with the broader set of federal rules we have about regulating false speech. And this is an area that I kind of have some despondency about when I sort of read how the court has been thinking about it. It's governed by this case called United States versus Alvarez, which involved this gentleman who is like a local water district board official who was fond of getting up at public meetings and bragging about his military service record. He also claimed that he was like a professional football player and had married a Mexican movie star. And one of the statements that he made implicated something called the Stolen Valor Act, which was passed to prevent people from lying about getting military medals. This Supreme Court decision about military medals has a profound effect on our profession's ability to regulate medical misinformation. Because the court in that case, even though it recognized that these particular statements, "I got a Purple Heart," don't have much social political value, they don't really generate any important speech or robust debate, to rule against Mr. Alvarez would create a sort of blanket rule that false statements were not constitutionally protected speech. And that the Supreme Court was unwilling to do because it feels that many kinds of lies do have value in the social and political sphere. They have value in making people feel free to express dissent with prevailing views without fear of repercussions, stimulating robust debate. And maybe more importantly, the court is deeply skeptical that the government can do a good job of setting a boundary between legal and illegal, or legally protected and not legally protected speech. They're not willing to entrust that to the government. So we're in a world where, although there are some limited classes of false speech that are illegal, like commercial fraud, for the most part, we cannot legally police these kinds of false statements, especially ones that are in scientific disputed areas like how does COVID get transmitted or how safe are vaccines. So that leaves us with a greatly limited toolkit for combating medical misinformation, unfortunately. The court is very bought into the idea that the solution to false speech is more speech. Now, we know from really voluminous research how difficult it is to dislodge beliefs that are prompted by misinformation. We're just outgunned, outmanned in terms of the quantity of information, the swiftness with which it moves, and the difficulty of moving people off of their default once they have it. So it's a deeply problematic solution, but it is what we have to work with. Again, medical boards can still go after these physicians for unprofessional conduct, but it's quite difficult, and they've been very reluctant to kind of stick their necks out and do that. So that has not proved to be an effective remedy, except in cases where they're sort of the worst offenders who are trying to peddle cures or something like that, in addition to just counseling patients. So it makes your role as pediatricians all the more important. We know that you are the most trusted medical specialty, and unfortunately, the courts have put it on you to stem the tide of misinformation. So I will pause there. There may be other legal topics that you want to discuss, and I'd be more than happy to do so in Q&A. But thank you very much for your engagement.
Well, thank you very much, Michelle, for that very informative and provocative talk, and we look forward to the Q&A. And next, we have the privilege of hearing from Dr. Kristen Beam, who's a neonatologist at Beth Israel Deaconess Medical Center and Boston Children's Hospital.
All right. Thank you so much for inviting me here today. Every time I come out to Palo Alto, especially entering the cold, dark winter that's about to come, I'm like, why do I live in Boston? But here I am.
We can do something about that.
Yeah. So today I'm going to talk about overcoming some challenges, specifically as it relates to data in AI and in the subject I know best, which is neonatology. So why should the NICU care about AI? Here we are at a maternal child conference, and I think the NICU is a really great place for AI, but why? And I don't think I'm the only one who thinks that. So there's, this is just a quick poll from PubMed, looking at the number of AI publications since 1990. We've seen a couple of other charts like this today. And so great, in 2024, it looks like we're up to just over 60 publications. But in other areas of medicine, so if we look at all medical AI publications, there's 17,000 publications. So the NICU is still very far behind. But like all of medical specialties is a large subset. So let's just look at one. So cardiology medical AI publications, they're still beating us at over 1,000 publications every year. But kind of our nearest neighbor, pediatric intensive care, still beating us with about 300 or so publications each year. So just to remind us, here we are in the NICU with about 60 per year. And I think that should be more. And why is that the case? The NICU provides a really special environment for data collection where a baby is admitted right after they're born, and then they're there until they go home. For the most part, there are some exceptions to that. And we collect all types of data. So we have physiologic monitoring, we have all of this EHR data, different aspects of pain control, medications, parental involvement, the exams that happen each day. So there's so much data that's available in the NICU that could really be beneficial for AI applications and we're just not tapping in to really even a subset of that. But let me tell you a little bit of a story about my data collection journey. So this is a picture of the Longwood medical area. If you've ever been to Boston in this area, there's like 5 hospitals within a mile of each other. My hospital is up in the top right corner. There's Boston Children's, which is that little green circle in the middle. And so let's look at a closer map of this area. So Beth Israel is where I primarily work. The Joslin Clinic is an adult diabetes center. It's 0.3 miles. Harvard School of Public Health, it's 0.7 miles from me. Boston Children's Hospital is connected to Brigham and Women's Hospital by a bridge. So I work here, but it is so hard to work with the data from each of these institutions. They're all under Harvard University, but the system is just very split up in this area. So my data collection journey began in about 2018. So I started my NICU fellowship in 2017. And in 2018, I wanted to predict bronchopulmonary dysplasia from chest x-rays in the first 72 hours of life of babies in the NICU. I said this was my project. This was before AI is what it is right now. And I kind of got a lot of crazy looks. Why are you doing that? Not basic science, that sort of thing. And I said, well, I'm going to do it anyway. So here I am, and as a fellow, we rotated through 4 different NICUs, Boston Children's, Brigham, Beth Israel, and Mass General. So I picked 2 that I figured, well, I'll just get data from 2 institutions because they were under the partners heading at that time. So that was Brigham and MGH. So I said, I'm going to get x-rays and data from these 2 institutions. Okay, so I have to file an IRB at each hospital. I have to get a DUA. Even though I'm allowed to use this data from each place, I have to go through all this paperwork and finally get the data, and we save it to a hard drive. And then it was 2020, and then I graduated, and I went to not a partner's hospital. So the data went away. So that just sort of, I'll get to the project again in a little bit, but that just illustrates the challenge with the data collection for all these sources. There are some great neonatal data sources out there. So there's the Vermont-Oxford Network, there's the Children's Hospital Neonatal Consortium, there's the pediatrics data set. MIMIC is a BI-specific data set, and then I can't come to California and not mention CPQCC. But I think they all have pros and cons. So VAN is really there for outcome labeling and for QI and benchmarking. CHNC is also for QI and benchmarking. And it's specifically level 4 NICUs, not really level 2 or level 3. Pediatrics gives you a lot of granular data output, but it has a ton of missing information, which we talked about already. MIMIC is just a single center. It's mostly adult focused. We're the only pediatric unit in Beth Israel. And then CPQCC is really meant for QI and equity research as well. So there's none of these databases so far that are really focused on AI research and the type of data that we need for AI research. It does give me hope that we can build these types of databases for AI, though. The other issue is when we have an AI question, I had someone come to me last week and she said, I have all this physiologic monitoring data, what can AI do with it? And I said, well, what's your question? And what outcome do you want to look at? So you still have to go back to what your basic scientific process is, even though we really want AI to be this magical thing that will answer all of our questions. So I told you about my data collection journey. We've talked a lot about different data types today, but what really is the right data to use for this kind of outcome, question outcome situation? So I'm going to talk about a couple of my projects and how we've explored different data types. So the first one is, are ICD codes the right data to use for outcome identification? So when I was doing this project where I was gathering all this data as a fellow, we figured, well, we can at least get ICD code data. That's easy enough to grab. So can we predict BPD just based on ICD codes? So we pulled these 4 different ICD codes from a single center, and we really wanted to understand just the sensitivity and specificity for an ICD code that's supposed to identify BPD in this one single center. So we had about 166 patients. We looked at less than 28 weeks for about 880 grams. That's kind of our highest risk for BPD. And we looked at kind of comparing VAN definitions of BPD with the ICD codes. We looked at just kind of the clinical definition of BPD, oxygen at 36 weeks. And then we looked at either oxygen or pressure, which is kind of the new definition we're going by, to look at the sensitivity and specificity of different ICD codes for this. So they're all pretty sensitive, but none of them are specific. So we really can't use those codes as outcome definitions for BPD. I do worry sometimes when people use ICD codes in their AI research, because if you're not sure that it's sensitive and specific for the diagnosis you're looking at, then your outcomes are not going to look great. The other interesting thing about the ICD codes, especially in a temporal-based definition like BPD, is that if you go into insurance claims databases and you look at the day the BPD code is assigned, it's often assigned on the first day of life. Well, that's not possible. Babies can't have BPD on the first day of life. They don't get it until they're 36 weeks. And this isn't saying that a physician is saying this 26-weeker has BPD, even though they are at high risk. It's just kind of how the data comes through. And we've discussed a lot about how you have to understand how that data comes through your database before using it. Okay, well, I still want to predict BPD, so I'm going to use an alternate data source. So for this one, we actually went to Pediatrics Clinical Data Warehouse. They cover about 300 NICUs across the nation, and they have an EHR system where they include daily EHR. They really built their EHR to collect research type data. So we defined our outcome, again, the flow-based BPD diagnosis that I talked about earlier. And we had a pretty large data set from this data source, so about 60,000 patients. We split it into a training, internal validation, and external validation set, and we based the facilities to make sure we weren't leaving out facilities in the training or internal validation. And we used what's called a transformer model for this project, and It's just a deep learning model that can be used in natural language processing tasks. And it really handles these long-term dependencies very well. So it handles the kind of longitudinal data that you might need to predict a diagnosis that happens down the road, like BPD. And then we calculated and we incorporated the daily data to predict the BPD grade. And what we overall found is that we could get an AUC of about 0.87 to predict BPD based off of this EHR data on the first day of life. And then we calculated it on each day up to day 28, which is similar to the current BPD calculator through the NRN. And we got up to 0.95 by day 28. I think that probably makes sense. By day 28, you're probably understanding a little bit more which patients are at risk. The previous models, which are basically the NRN BPD calculator that's out there, were about 0.6 to 0.7, up to 0.8 by day 28. What was interesting in this study, by using this transformer model, what we were also able to look at was different patient trajectories. We were able to see that, so these are 3 different patients. We can see one gets no BPD, one gets grade 3 BPD, and one baby dies. And so what we see is red is any type of BPD, green is mortality, and blue is no BPD. And you can track them over time and sort of see, as the data gets pulled into the transformer model, we have a different view of what may ultimately happen to that patient. Based on that, we can also look at things like model confidence, which shows us, how confident is the model. This is kind of what we've been talking about when a model is saying, I don't know, which is really useful both as a kind of hypothesis generating point, but also just to help us talk to families and patients. So here the model was least confident day 3 to 7. If you treat these patients, you know that most of our interventions target day 14 to 28. And then, so what can we do at day 3 to 7 to maybe change our trajectory down the road? So that's the really interesting thing that I think came out of this model. Other groups here have used EHR data to look at different neonatal outcomes, and kudos to you guys here for getting like 32,000 patients from EHR data. I think that's great. So there is hope for using EHR data. And then we've talked about Epic Cosmos today. So is this one of the solutions for how we use EHR data? Do we have what they're doing at Sick Kids come in and help us transform our medical records so that we can use this data and have this clean data and understand it? I think we're still just on the cusp of how we can get to that point, but there are steps moving forward. So that's kind of EHR data, which I think a lot of AI has really been focused in that aspect, but we have, like I said earlier, lots of other types. So can we use physiologic waveform data? And one group at UVA has looked at heart rate characteristics in the NICU and developed this score called the HERO score. It looks at heart rate variability. Ultimately, they did a randomized controlled trial and actually implemented this, and you can purchase it for, I have no stake in HERO, but you can purchase it for use in your hospital, and it can give you a score that suggests the likelihood that a baby would develop sepsis in the next 24 hours. The problem with this, as we talked about earlier, is that this has been a randomly tested algorithm, but it's really not implemented nationally, even though we know it decreases mortality. And so there's a lot of steps to really what it means to implement one of these algorithms as well. Okay, and then back to my original question, which was, can we predict BPD from imaging data? That was always my initial question. It sort of came around after some of those early retinopathy or just the retina papers that came out where they were predicting other things from those retinal images besides just retinal eye disease. They were predicting things like blood pressure, age, sex, different things from these images. And so in that way, could you use early images, chest images, to predict BPD? Which is not what we get the early chest images for. We get them for line placement, respiratory distress syndrome, surfactant delivery, but can you predict something else down the road? So finally, it's 2024. I got my chest x-ray data set that I tried to start getting in 2018. it's a single center data set, so now I'm just using Beth Israel data, but it took that long to really get this data. So and then large language models came out and have really shifted how we're doing things as well. So what we did with this, we had a collection of about 30,000 chest x-rays, and we have about 26 matching radiology reports. So we used a large language model to extract the diagnosis from the radiology reports. Once we extracted the diagnoses, we trained a contrastive language image pre-training model to predict the outcomes from unlabeled radiographs. So let me walk you through this a little bit. So I'm showing you it wasn't ChatGPT, but I'm just showing you ChatGPT for just effect. So we would prompt the LLM based on the wording in this radiology report. Can you determine if there is atelectasis present or not? We would feed it a de-identified radiology report. I'll show you the chest image that goes with it just to prove, sure, there's some atelectasis here. And then it would tell you, 1, yes, atelectasis is present according to the report. So we did this for a lot of different diagnoses in neonatology, pneumonia. I'll show you a couple other ones later. So then we took the images, we matched them to their diagnosis, trained this model on a prior adult model, sort of fine-tuned this one to match these different diagnoses. So line placements, different atelectasis, pneumatosis, things like that. And this is early unpublished data, so we are still working on the final manuscript and everything, but this is what we ended up with. So we compared a logistic regression. The BioVil is an adult trained model, and then our model is in the last 2 columns. And what we can see is that our AUCs for predicting these different diagnoses is highest in all the red categories. So except for UVC placement, which is a little bit higher by the BioVil. I would say that one's maybe not as specific to some of these other diagnoses. What's interesting, and we're still trying to figure this out, usually in neonatology, when you add gestational age and birth weight, it fixes everything, and that's what predicts every diagnosis we have in neonatology. And in this model, for some reason, which we're trying to understand, gestational age and birth weight did not improve our outcome or our AUC for this model. But I can't leave this without talking about just some of the issues, especially with using images for some of this, for some of these AI applications. And one is something called shortcut learning. So in this paper, they tried to sort of trick the algorithm and see what it was using to come up with their predictions. So in the bottom, we see there's a little A, a watermark. And so in a lot of images, there is a watermark that appears. And when they used this just convolutional neural network and tried to see what the model was looking at, it's really focusing on the A for the shortcut. But when they used this contrastive language image model, which is what we used in our study, it does not pay as much attention to the A as it did prior. So this is just something to be aware of, because when we have all these images, there are some extra layers of data that are present, and so you have to understand what is actually driving that prediction. And this is especially true in gaining trust from our patients when we're using these images. And then finally, we've talked a little bit about algorithmic bias today, and it's important to know that, like everyone has talked about already, that medical data holds biases, and we know this to be true. In a paper from MIT, they looked at different underrepresented groups and saw that they were actually at risk for underdiagnosis. And I would think that, from this paper, it shows that younger patients are one of these groups that have underdiagnosis. So if we don't have data on certain groups, like we were talking about earlier, pediatric patients are typically healthy, and so they're not presenting with diseases, then we won't be able to predict those outcomes if we don't have that data. And then just because there isn't data on a group doesn't mean it's a healthy group. So just to summarize, and happy to answer questions after this, so some takeaways for this is we have to have the right data for the right question. You can't just come with data and say, how does AI help me here? Temporal questions, things like temporal diagnosis like BPD, may need specific types of data or specific models. We have to understand the biases that are present in the data, and my hope is that multimodal data sources will really help. So how do we get to the future of AI in the NICU? We have to move past tabular data into these multimodal sources, safely collect data, define our outcomes. And I think we can achieve that through data sharing, collaboration, and education of others. All right, right on time.
Great. Well, if I could invite our other panelists to come up, please. Thank you. Great talks. Thank you very much. And we have 2 microphones here. Please, we welcome comments, questions from anyone in the audience. Tony.
Thank you so much, the whole panelists, for this talk. We heard in the first session about how to clean our data, how to get it from Epic or Cosmos or whatever into a... but then we also heard in this session that clean data is not the only thing. We have to know about the rules and the local rules. And so as the rules change, we have to clean and unclean. How do we propose to do that in a health system that might be used for and against our patients in different times, and that may be subject to interpretation as well? Your thoughts would be very helpful.
So in the last session, Dr. Stevenson asked about, for example, the false weights, the misfingered, kind of outcomes. And I'll channel my mentor, Dr. Butte, who had this great slide where he had mapped Packard Children's data, and it was thousands and thousands of patients. And on a growth chart, he had some pancakes, which were people who were like 1 inch tall, or 62 inches tall. But had a normal weight. And then he had string beans, which were the people that were 10x taller than they should be. And it wasn't very hard to clean up that data because there were some things that just weren't physiologically feasible. But a tool's point was that when you're dealing with real world data, as opposed to this manually curated Vermont-Oxford network kind of data set that's really been cleaned, that you have to address that type of stuff. But oftentimes the quantity of that data can help you. And so a tool also had another slide where he showed that even without filtering out that data, just the sheer quantity of the real world data helped to overcome it. So I think there are some important points when it really is significant, particularly when you're dealing with smaller data sets and neonatology and other things. But it's a different approach, I think, when we're using real world data. And we have to acknowledge it's not perfect, but there are things we can do, including size of the data, to overcome limitations. Dr. Stevenson has a comment.
I think that comment about scale is really important, and I remember Atul telling us about that as well. We, of course, initially objected to his observation, but it does turn out to be true when you're dealing with very large-scale data sources. But some of the things in pediatrics are, of course, smaller scale, so you have to be very careful about the quality of those data and doing your analyses. Kristen, I was listening to your presentation, and it reminded me of some of the things we're thinking about now, which are really, I think, important in neonatology. One is the notion of a whole new taxonomy for preterm birth. Whereas we tend, as neonatologists, to lump things into, 28-weekers or 34-weekers, and we have a general idea developmentally of what might be score for those children. But in fact, it may be quite different than that in reality, and I think the tools you're using are likely to be extremely powerful in helping us to identify the health trajectories of babies even before birth. And I think that's really, really an important thing that you're doing. And your data looks really, really promising, so I'm really glad to hear from you in person.
Yeah, and I would say on that note too, in neonatology, I think we have a hard time defining our outcomes very clearly. Specifically BPD, like we've defined it in, 10 different ways, and I always joke and say if you ask probably 10 neonatologists, you're going to get like 20 different ways to define a certain disease. And so I hope that some of this sort of prompts us to really think about even more physiology-based diagnoses too, because BPD is not a physiology-based. So yeah.
Great. Yes.
Great. Hi, Suhail Hussain from GI. What really caught my attention was the comment that you made about large language models in medicine and other fields being able to say, I don't know. as physicians, oncologists will say you have a 10% chance of success. We'll still do it because we know that those are the odds. Or a biostatistician will give confidence intervals. Well, large language models, for some reason, just can't accept it. Like, you'll ask for medical literature, and it'll be notoriously wrong, and it sounds so confident until you start plugging it in.
It's like an intern.
And so could there be like a mandate for large language models to provide some sort of confidence score, percentile range, such as I'm 0% certain about this reference?
I like your idea very much, and I know that there are people smarter than me working on this problem. One of the things that we're excited about is retrieval augmented generative AI, or RAG, which can decrease not only hallucinations, but it gets you a little bit more of that precision around the confidence. And Dr. Naumann, who I talked about, has actually done some work combining traditional machine learning with LLMs. So I'll just give you a really quick example, because they cracked the nut on sepsis in the emergency department, which is fantastic. We also suck at postoperative sepsis. So that's where I've set them now. And postoperative sepsis is really difficult, as many of you know, because the physiology resembles postoperative, sort of normal physiology. And so our models were really poor, and they weren't worth implementing until we added large language models. And it turned out the addition of LLM got it to a threshold we felt comfortable putting it in production, and we're actually randomizing it as a QI project now. So clearly the LLMs were using data that were coming from the text generated by our residents writing accept notes in the intensive care unit, and our surgeons, dictating or writing procedure notes. What was funny is that we then went back and we added the LLMs to the emergency department notes to see, could it improve the accuracy of the ED sepsis tool? And the answer was, it didn't at all. When do the emergency medicine faculty write their notes? Like the next day, like after they go home, after the patient leaves. And so from a workflow standpoint, the data wasn't there to inform it. And so it's just another really good example of how, the implementation and the workflow is sometimes the real challenge. We also added LLMs to all of our traditional MLs algorithms in production around readmission risk, mortality risk, insurance denial risk, et cetera. On average, it got 8 to 12% more accurate. And we presume that's because what it's getting out of the note data is a lot of social determinant data that we don't encode discretely today.
I also think people forget that LLMs, its only job is to predict the next word in the sentence. So it's not, unless you train it in a certain way and perhaps fine tune it on, specific notes and everything, it's only going to say what it thinks the next word is. And so with that, it's always going to have an answer for what that next word is, whether it's true or not.
And I would just add, if it is going to attach confidence rating, it better be really confident about the confidence ratings, right? Because what we have going for us right now with physician interaction with LLMs is suspicion, like a high index of suspicion in approaching every draft. But if you are a busy person looking to triage which of these 100 AI-generated emails should I focus on today, the natural tendency will be to drift towards the ones that the AI is less confident about, regardless of whether it's right about that.
Council has spoken.
Great. Yes.
So in this session alone, we have seen 2 examples of algorithms that are able to say, I'm not certain, I don't know. And that's certainly better than giving the wrong answer confidently. But so what? What comes after that? After it has said that, I don't know, have you seen examples of places where it can say, but if you had this information, then I'll be able to help? Or any other ideas on what comes after I don't know?
Yeah, I think I presented about the model confidence, and I think right now all it alerts us to is to say, well, what is happening in that time to make the model less confident? So I think right now it's just generating questions about that time period and what we as physicians should maybe focus on in our next research step. I don't know of next steps from models quite yet, but that would be definitely the place to go.
Thanks so much. Great talks. Keith Morse from Hospital Medicine here. This quick question I think is for Chris and Michelle probably. Help us think through build versus buy for LLMs sort of in the long term? And then sort of, Michelle, the legal implications of that. I mean, health systems used to think that they should build their own EHRs, and we've sort of evolved out of that. Are we similarly early with LLMs, thinking we should build our own LLMs when we should just let the tech companies do what they do best?
Go ahead.
Yes. It's a tough question. I think part of the role of academic medical centers is to innovate and lead for the entire industry. And yes, hospitals used to build electronic health records, but without that happening at Utah and Brigham and Vanderbilt and many other places, you wouldn't have Epic and Meditech and Cerner. And so I think similarly, places like Stanford and some of the University of California hospitals can lead the way to show what's possible, but ultimately our CIOs will likely look for vendor partners that they can both benefit from scale and hold accountable.
Yeah, I mean, I guess from a liability perspective, the advantage of having another potential defendant at the table if something goes wrong is clear. But there are a lot of questions about whether and how you can hold these product developers liable for software-related errors. Like, there's just very little case law that indicates you can hold developers liable when their software is not embedded in a thing and causes physical injury. It's new ground. And also, it opens up the door for injured patients to be able to say, look, this thing was trained on a population that's palpably different from what you used it on. So regardless of their presence at the defendant's table, that's on you. Whereas, at least with homegrown things, we have a small data set, but it's our data set, and we have to worry a little bit less about drift and safety problems arising from that.
Yes.
Hello, my name is Simon Lingwood. I'm a pediatric informaticist turned local entrepreneur. Thank you very much for this panel. In the talks, we heard both Stanford and UCSD from the early days licensed a local version of ChatGPT for privacy and for encouraging the innovation. My question to the panel, especially to Dr. Miner and Dr. Longhurst, is your thoughts on the future of edge AI data centers. We know, in your viewpoint, do you see the future is largely centralized AI data centers, or it's more of in the old days we see many departments have their own data centers, even some smaller AI data centers in the office of faculty members' offices? Where do you see the future is?
Chris, you want to start?
Yeah. Sure, thanks, Lloyd. It's a great question. I guess my short answer is that no, I don't see data centers in faculty members' offices as being part of the answer. However, I will say that if we look at, for example, AI ambient documentation, of course, we're doing a pilot like everybody in the US. And part of the challenge of that pilot is, number one, the privacy concern about sending data to a cloud. And number two, I'm doing a pilot because an enterprise rollout would cost $4 to $5 million across UC San Diego, and that's not in our budget. What I'm really excited about is that I can now run a 16 billion parameter model on my laptop. And if that approaches 97 or 98% accuracy of what we can get from a GPT compute, then I no longer have to send data to the cloud. I can do it at the edge. So I don't think we're going to be storing data, locally, but I think the edge compute is going to be critical. And truthfully, I don't even know it's going to need a laptop. I think pretty soon a lot of these models will run on a mobile device. And if I can do AI documentation using my mobile device, never send the data to the cloud, my counselor is happy, I'm happy, privacy is preserved, and cost is way lower.
Thank you. So first of all, I want to thank all the panelists. I thought that was an extraordinary session. And Michelle, I especially want to thank you for bringing your perspective, because the issue of the no-shows has come up multiple times now. We had an integrated strategic plan retreat the School of Medicine did last week. I actually raised it around the health equity question. Natalie gave a beautiful example this morning. And as we've all been very keen to the health equity implications, but never had thought about the legal implications and the issues around discrimination. So I think really all of us in MCHRI leadership need to think about what are we going to do proactively to educate our community around this issue. Chris, I was really curious. given all the work you're doing, and so the question's really for you, as you were listening to that presentation, has your program been thinking about the discrimination spin or a perspective on all of this and the potential legal implications?
Yes, and first of all, I would say it's a team, right? So we now have a Chief Health AI Officer, a CIO, CMIO, a lot of other folks very involved with this. And our legal team has been close partners on this. There are all sorts of risks and concerns that they're bringing up. And the interesting pressures that we're trying to balance is, on the one hand, we have clinicians saying, give me ambient documentation now. And my CEO saying, give me AI-enabled efficiency in rev cycle now. And on the other hand, we have a legal contracting process that's intended to protect the organization, reduce risk, and is identifying all sorts of unknowns that we haven't encountered before. We also have a lot of organized labor, and I've spent now 3 or 4 calls with our nursing unions and others talking about their concerns about some of the AI implementation. So there's a lot of sort of dichotomous pressures, and in many ways I would like to move faster, but the balance is playing out in an appropriate way, which is that we have to think through all of these risks before we move things into a production environment. What do you think?
I do think as we get more experience in just reviewing more and more tools, like we can get out ahead of the life cycle problem by recognizing that tools will start to group themselves into different buckets that raise similar concerns.
Yeah.
That can be anticipated and a playbook developed for them ahead of your team coming to you saying, we're ready to go, let's do it next month. So one of the things we're doing here at Stanford with a grant from PCORI and Stanford Impact Labs is trying to develop this kind of playbook around ethical issues that arise, but the same thing that can be done for legal issues. So you've got a clinical summarization tool that's LLM based. Those are going to raise really common issues across use cases, and if you've got people thinking that through, again, ahead of specific proposals coming to you, then you're much better situated to be able to do governance without slowing things down.
Yeah. I think that the ethical issues go further as well. I mean, we think about the clinical side because many of us here are clinicians, but when we start looking at some of the business efficiencies, there's all sorts of opportunities that will, fundamentally change people's job roles. And we have to prepare for that in advance, whether that's retraining, repositioning, keeping positions open, et cetera. We were talking last night about the dock worker strike, and their demands were not only 60% compensation increases, but 0% efficiency improvements from automation. And healthcare is not going to tolerate that because there are a lot of opportunities for decreasing administrative friction.
We'll go to David, but let me ask each of you to think about, as a closing question, 2 parts. What are you most excited about and optimistic about in terms of the implementation of AI? And what can we do to make that a reality? And then the other side, what are you most concerned about in terms of risks? And what can we do to try to mitigate or eliminate those risks? So I'll give you a chance to think about that, and then we'll go to David's question and then do the wrap up.
Well, maybe you can think about this at the same time, which is that, when I think about freedom of speech, which is a big issue on all of our campuses now, the freedom of speech in the context of healthcare seems to be a little bit different than the freedom of speech we encounter in other areas, in the sense that as physicians, we don't want to do harm, first and foremost. So the things that we say or agree to can have a different kind of an impact on a population or on individuals than you might have with someone claiming that they got a medal, in the military or something of that sort. So I see it as a real challenge for medicine in particularly around the issues of healthcare and misinformation, just to think about that as well.
Thank you. Michelle, do you want to?
Well, Dr. Stevenson, I think you and I are very much aligned on this point. As you know, it does seem very different to me, and it bothers me that the courts are unwilling to consider even palpable and imminent physical harm as a reason to regulate speech. And it traces back again to their core belief that might well be a compelling interest. They'll say it is very often. But the second part of the legal analysis is you have to show there's no other way to get at the problem that's less restrictive of speech. And there the courts are just very willing to believe that you all can do a good job of counter-programming people in the face of this misinformation. So I think we're stuck. I don't see a way out of that other than getting better at the counter-programming.
Great, thank you. Well, Chris, can we talk with you? Can we start with you first?
Sure.
What you're most excited about?
Yes.
Second, what you're most concerned about?
Okay. Little audience interaction here. How many in the audience have had a friend, family member, or loved one who's had a missed or delayed diagnosis? Okay. So generally, it's about 50% of the people in any room. It's the #1 cause of medical malpractice lawsuits. It's the #1 cause of medical malpractice settlements. And part of the original vision for AI from Warner Slack and Larry Weed in the 60s, Ted Shortliff here in the 70s, was that AI would help us with diagnosis. And so one of the things I'm most excited about is AI-assisted diagnosis, totally transforming healthcare delivery. I think this is going to be the biggest thing in healthcare since antibiotics. And we were talking about this last night from a medical education standpoint. I think it fundamentally transforms primary care because the dirty little secret is 50% of doctors are below average. Of course, none in this room. But I think AI-enabled clinicians, as Dr. Langlotz suggested, are going to be superior clinicians. And so that really excites me for the future of healthcare. What I'm most worried about or scared about is not Skynet. It's that we fail to take the opportunity to really use AI to address patient safety, which is an unsolved issue here 25 years after the IOM report.
Thank you. Michelle?
I'm actually more excited about something much more modest and shorter term, which is I think that we will make huge inroads in relieving some drudgery from clinicians' lives. Not this year or next year, but within 5 years, things will be good enough that we really can trust these clinical summarization models, in-basket models, things like that, to try to lift away some of the pajama time. In terms of what I worry about, as an ethicist, I feel like today's been another example of where I see people talking about the ethics of AI solely in terms of bias and fairness. Those two terms are virtually synonymous in the field, and they're not synonyms. As we've discovered doing ethics reviews at SHC, there's so many other issues that arise when you put humans in contact with decision support tools that I think are not being addressed, that pose safety risks, that pose liability risks, and that people are just not tuned into yet. And I'm concerned that the leading AMCs will tune into those and put good governance processes in place, but there will be differential protection of patients who are served by lower resource and less experienced institutions.
I am excited that neonatology is kind of paying attention to AI now, and hopefully that will continue and we will really see some predictive ability of AI to improve some of our neonatal outcomes. I think there's a lot of steps in between now and then, but I think there's at least interest now, and we can start to explore how that needs to happen. Things to support that to happen are definitely collaboration. We have to both collaborate with clinicians and computer scientists to be able to make this happen, because neither one by themselves can do it, and then collaborate between institutions. I have a group, it was mentioned a little bit earlier, called Neomind AI, and it's just a group of neonatologists across the country who are just really interested in how we can bring AI into neonatal care. I would have to piggyback on top of what you said about not taking the opportunity, because I think healthcare lags behind a lot of other sectors for technology advancements. It takes us a long time to implement an EHR. I was an intern not that long ago, and I did paper orders also in Boston. So it takes a long time to really get a lot of that stuff pushed forward, and so I hope that we actually move forward. And I think some of that will be done in conjunction with the tech companies. So I think they have resources that just healthcare doesn't have, and so if we can join forces in a ethical way with tech companies, it'll really help push things forward.
Great. Well, thank you. Please join me in thanking Chris, Michelle, and Kristen.